Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Today's podcast will focus on immunoglobulin A nephropathy. We're joined by Dr. Bomback. Would you like to introduce yourself?
Sure. Hi, my name is Andy Bomback. I'm a nephrologist at Columbia University Irving Medical Center, where I co-direct the David Koch Jr. Glomerular Kidney Center. And IgA nephropathy is by far the most common diagnosis we see there.
Thank you, Dr. Bomback. Dr. Kelly-Purvis, would you like to introduce yourself?
Sure. Hi, I'm Ellie Kelly-Purvis. I'm a professor of medicine at the University of Pennsylvania School of Medicine in Philadelphia. My interests are advanced chronic kidney disease, and adjacent to the university hospital is a very large East Asian population, primarily IgA nephropathy, and we have the opportunity to care for those patients.
Thank you, Dr. Kelly-Purvis. And Dr. Radhakrishnan, would you like to introduce yourself?
My name is Jay Radhakrishnan, and I'm a professor of medicine at Columbia University. And together with Andy Bomback, we're part of the Glomerular Center, which was quite unique in terms of patient care, education, and research. And as Andrew said, IgA nephropathy certainly is the commonest glomerular disease we see.
Great. Thank you, Dr. Radhakrishnan. So the question that we'd like to consider is what's the role of combination therapy in the management of IgA nephropathy? Dr. Kelly-Purvis, in combination therapy, is combination therapy a new concept in the treatment of IgA nephropathy, and how do we get here? What was the standard treatment approach before combination therapy?
I think the standard treatment approach before combination therapy was foundational therapies that really related mainly to progressive chronic kidney disease, the underlying kidney disease, rather than the immunological presentation or problem with IgA nephropathy. Those foundational therapies included RAS blockers and lifestyle modification, and as well as blood pressure control. And really the goal was to maintain GFR, but never really achieved that goal. Subsequently, the appearance on the spectrum of treatment of IgA nephropathy, both combination therapies that target the underlying CKD process and nephron loss, as well as attacking the immunological basis with the IgA production and immune complex formation, really has transformed the way we treat IgA nephropathy. And we believe, we all believe that foundational therapy is important as a now not only a first step, but stacking other therapies, combination therapies will really transform the natural history of the disease. We hope and we believe it will.
Yeah, IgA nephropathy is really, amongst the glomerular disease spectrum, I think one of the best examples of how we've learned so much about the pathophysiology of the disease and how much that influences the way we make treatment decisions. So there is a very well established 4-hit model now that most people are aware of with IgA nephropathy in terms of how the disease occurs. Hit 1 being the production of abnormal or galactose deficient IgA1 molecules. Hit 2 being the production of unique autoantibodies that are directed at the galactose deficient IgA1 that we call anti-glycan antibodies. Hit 3 being the formation of immune complexes of the galactose deficient IgA1 as an antigen, the anti-glycan antibodies as the autoantibody, and that immune complex formation being hit 3. And then finally hit 4 being the deposition of the immune complexes in the glomerulus and inciting an inflammatory response and eventually kidney injury. And so we know now these steps in the pathogenesis, and what's so exciting about IgA nephropathy when you treat it is that we have therapies that really work at all of these hits. So some of the conservative therapies that Dr. Kelly-Purvis just discussed, things like renin-angiotensin-aldosterone system inhibition, those are more sort of aligned towards hit 4 and the effects of hit 4 in terms of trying to slow down the progression of the disease and the chronicity of the disease. But for a while, when we tried to immunologically modify the disease, we really were limited to just prednisone. And prednisone probably works mostly at hit 4 as well as an anti-inflammatory. May have some effects in the earlier hits in terms of the assembly of these immune complexes. But now we have diseases that are really being promoted as specifically working at one of these steps. So, for example, budesonide, or targeted release formulation of budesonide. Really, the way we're told that drug has its best benefit is that going after hit 1 and trying to reduce the formation of galactose-deficient IgA1 molecules for the secretion. We have a bunch of B-cell directed therapies that are in the pipeline, things that block APRIL and BAFF. Those seem to have effects at both hit 1 and hit 2. We have complement inhibitors that are in studies, or one that's already been approved, iptacopan, and those drugs are probably having their biggest effect at hit 3 and hit 4. So when we think about combination therapy, we actually can use physiology to say, well, I'm going to take a conservative therapy or 2 or 3 conservative therapies that go at hit 4. I'm going to add an immunomodulatory therapy that works primarily at hit 2. And we're really able to do a much more precise and insightful combination therapy with IgA nephropathy than we do in most glomerular diseases because the physiology has been worked out so nicely.
The way I look at IgA nephropathy is that, it's different stages of the patient's, I would say, lifespan. It's a lifelong disease, may have different manifestations in terms of inflammatory IgA versus a predominantly fibrotic IgA. And the treatment approach is quite different when you look at either end of the spectrum. For example, if you see the patient for the first time with a lot of proteinuria, which is a very high risk factor, we have a very inflammatory MEST score, so M1, E1, and maybe C1. This patient should be sort of really treated very aggressively with one of the proximal hits in combination with the distal hit. So we really need to throw multiple combinations at this patient. And as opposed to the same patient, say in 10 years, and you do a biopsy for a proteinuria of 2 grams, and we find predominantly fibrotic lesions with virtually no inflammatory lesions. In such a patient, we would not expose them to immunomodulation or immunosuppression, but really focus on keeping the anti-fibrotic aspects of treatment in place at this point.
Yeah, I think that's a really important point. The identification of different phenotypes of patients really will determine what types of treatments would be used in those patients. And I think we have a general idea, but we don't really have specific therapeutic interventions until we have specific therapeutic interventions, but different phenotypes of patients have not fully been defined yet to really look at what really will be effective in one phenotype versus another. And since the unmet need really is that we have to decrease the progression of kidney disease to end stage, decrease eGFR. Identifying the patients early on is really key to really treating patients effectively with this disease.
I'd like to just expand on Dr. Calibros's idea, saying that all the clinical trials that we have currently are using the newer targeted therapies on top of conservative management, or what we call foundational therapies. There are no head-to-head trials saying which of these targeted therapies are in combination are better than the other, or is it simply the phenotype of the patient is not really defined in these trials. Everyone with a minimum proteinuria and a maximum GFR or minimum GFR is put into one trial, but without sort of trying to elucidate which patient might benefit from a particular targeted therapy. So that's, as Dr. Calipro said, it's a huge unmet need, is really getting a personalized medicine approach for the patient who's sitting in front of you.
And furthermore, we don't really have validated biomarkers other than proteinuria and slope of GFR really to determine a chronicity of disease or response to treatment. So validated biomarkers are really important. Thinking that galactose deficient IgA would be one of those markers. In fact, it is reduced by different therapeutic interventions, but it has not really been validated to be really the only thing that we're looking at. So really we need to further expand and find these validated biomarkers. Therefore, we can have more precision medicine, as Dr. Radhakrishnan said, individualized medicine for each patient.
I think from an algorithmic standpoint, I really like the way Dr. Radhakrishnan doesn't call it conservative therapy. He calls it foundational therapy. It's like it actually paints a much better picture of what we're trying to do, because conservative therapy means it sounds like we're not doing much, but foundational therapy really, to me, says that every patient needs this floor upon which we can consider doing more. So for foundational therapies, we heard about renin-angiotensin-aldosterone system blockade. I think as we move into third generation mineralocorticoid receptor antagonists, it's going to make a lot of sense to use them on top of an ACE or an ARB. I don't think we've mentioned SGLT2 inhibitors yet, but this is the right time to mention them. I think the more and more data we see on their use in kidney diseases across the spectrum, and including very nice data in IgA nephropathy, pretty much every IgA nephropathy patient, you have to start by saying, should this patient be on an SGLT2 inhibitor? And the majority will actually meet criteria from the studies just based on them having protein in their urine. There's probable routes to getting many of our patients on GLP-1 agonists, again, as part of foundational therapy. And now with endothelin receptor antagonists, which aren't immunomodulatory, I think those should be considered part of the foundational therapy as well, to really maximize the proteinuria reduction. So when we talk about algorithms, there's not like treatment algorithms with IgA nephropathy. There's more of a guiding principle with IgA nephropathy, which is that no proteinuria is low enough. You just got to keep trying to get the protein as low as possible. And what the foundational therapies are really doing is trying to get to that lowest available protein level that you can get. And so you're adding an endothelin receptor antagonism, whether it's a combined angiotensin receptor, endothelin receptor blocker into one pill, or just adding an endothelin receptor antagonist on top of coexistent ACE or ARB. I think that's going to be, or it should be, part of foundational therapy, as long as our patients have access to these drugs. And then that's when I think about the algorithm of treating IgA nephropathy, that's what everybody should start with. And then the next question is, does the patient need something on top of that modulates the immune system? And I completely agree with what Dr. Radhakrishnan said, which is, if there's a biopsy that's recent that shows inflammation, and whether we want to say it's based on an Oxford score or just based on what your pathologist is telling you in their read of the light microscopy, but you can pretty much know if there's activity or no activity. And if there's activity, then you generally want to add something immunomodulatory to prevent the ensuing fibrosis that would happen from unchecked activity. And then the real art at that point is, now that we're in this embarrassment of riches stage of IgA nephropathy, of having more than one immunomodulatory to consider, the real art's going to come into, well, which one do I use? And again, Dr. Kalapura said this very clearly. We are in desperate need of disease-specific biomarkers, and I would just sort of add, we need disease-specific biomarkers that actually give us a clue into where, in that multi-hit model we talked about earlier, the disease is really having its biggest effect. Right now, I think the biopsy is the only real biomarker we have, and it's an invasive biomarker. But like sometimes you'll see on a biopsy that there's more C3 than a typical IgA would have. And if that's the case, then you might think about using a complement inhibitor. If you have, a real heavy burden of immune complexes, maybe that would tip you more towards a B cell targeting therapy.
Andy, as you were talking, I was thinking about the discussions that we're having relative, also similar to what cardiologists are doing, that is pillars of care. So there's foundational pillars of care, and then there's, active treatment beyond that. And so stacking medications and going from pillar to pillar, I think, is going to be really very important. And who are the patients that you're going to select for this advanced care, I think, remain to be determined based on, the biopsy. I believe I agree, and just validated biomarkers other than proteinuria alone. But I would submit, though, that it would be very hard in the current embarrassment of riches, as Andy very eloquently pointed out, to stay with foundational therapy for a long period of time. This is a very aggressive disease. When on diagnosis, almost 50% of those patients already have advanced CKD stage 3 or stage 4, and younger patients are ending up on dialysis. 50% of those patients end up with advanced CKD and dialysis within their lifetime. So I believe that we're moving to more aggressive treatment from the get-go, foundational therapies in addition to disease-modifying therapies or immunomodulatory therapies at the beginning of diagnosis. And I think that the biopsy would be really a very important tool to determine that.
And I'm just going to spend a couple of minutes talking about the current situation. Is if someone walks into my clinic today and we have a diagnosis of IgA nephropathy, they're going to leave with 4 to 5 medications at the end of the week or 2 weeks. And it's a significant pill burden, but I think the realization is that with combination therapies, we provide them with the best chance of living a end-stage kidney disease-free life as long as possible. Now, true synergy has not been documented. As I was saying, unlike goal-directed medical therapy that Dr. Kellypour mentioned in heart failure, is not been shown in IgA nephropathy, and that is something we really need. I mean, does adding an MRA to a SGLT2 to a RAS inhibition, and then you add on combination sort of hit 1 and hit 4 therapies, all these are unanswered questions, and I think it's up to the practitioner to decide, at this point in time at least, what is the best combination. There's no cookie cutter approach, as Dr. Bomback is saying. You don't go step 1 through 4. They have to be thought of individually, and we take a snapshot of the patient at every visit and say, okay, what else can I do that's helping the patient, and more importantly, not harming the patient? Because as we keep adding on therapies, there are risks from, say, liver toxicity, from hyperkalemia, and so on, that needs to be monitored very, very carefully.
Great. I'd like to thank our experts for sharing their insights with us today. We hope this podcast will be valuable for you in the way you treat your patients. We look forward to having you join us next time.